Which of the following is true regarding the diagnosis of aortic dissection? A. Magnetic resonance imaging is more specific than CT or transesophageal echocardiogram. B. Chest X-ray is normal in most cases. C. Transthoracic echocardiogram is useful to confirm the diagnosis. D. Aortography is the best screening test. E. EKG has excellent specificity. A. Magnetic resonance imaging is more specific than CT or transesophageal echocardiogram. Answer A. MRI is the most specific test for the diagnosis of aortic dissection. Logistic difficulties prevent routine use of MRI in this setting. For this reason, CT aortogram is the most commonly used test and has excellent sensitivity and specificity. Chest X-ray is abnormal in most cases, but the sensitivity is not high enough to rule out the diagnosis in high-risk patients. Transesophageal, not transthoracic, echocardiography may provide useful structural information about the descending aorta, heart, and pericardium, but CT aortogram and MRI are far more specific. Aortography is used only in confirmatory settings. Electrocardiography is useful only in ruling out other causes of the patient's symptoms and have no utility in confirming the diagnosis of aortic dissection. A 65-year-old woman presents to the emergency room with signs and symptoms of digitalis toxicity, ventricular tachycardia, and a digoxin level of 8.5 ng per ml. She is treated with digitalis antibody fragment therapy and the cardiac rhythm reverts to normal sinus rhythm. However, a repeat digoxin level after the fragments are given is 12 ng per ml. Which of the following is the most appropriate next step in management? A. No acute therapy. B. Cardioversion at 50 joules. C. Procainamide 1 g IV. D. Calcium chloride 1 g IV. E. Potassium chloride 40 MEq IV. A. No acute therapy. Answer A. The standard serum digoxin assay measures levels of all digoxin in the body, including drug-bound to Fab fragments. It is not useful to measure digoxin levels once Fab has been given. Precedence should be given to dialysis to remove the drug-Fab complexes. Cardioversion may be performed in unstable patients, but is unlikely to be curative in patients with digitalis toxicity. Procainamide should be avoided in patients with digitalis toxicity as it may exacerbate dysrhythmias. Calcium chloride should be avoided in patients with digitalis toxicity to prevent theoretical risk of stone heart, which occurs from massive calcium influx into cardiac myocytes causing sustained contraction. Potassium chloride should be given with extreme caution in patients with digitalis toxicity, as hyperkalemia is life-threatening in this setting. Which of the following is usually the earliest symptom to occur in patients with aortic stenosis? A. Lower extremity edema. B. Angina. C. Syncope. D. Orthopnea. E. Paroxysmal nocturnal dyspnea. B. Angina. Answer B. A. As usually occurs due to congenital bicuspid structure, calcific degeneration, or rheumatic heart disease. The classic murmur is a systolic crescendo, decrescendo murmur at the right upper sternal border or cardiac base. The natural history of AS usually follows a sequence of findings, starting with angina, followed by syncope, and then heart failure. As each subsequent finding occurs, the mortality increases significantly. Valve replacement is the only definitive treatment once symptoms appear. According to the current guidelines for TPA administration, Which of the following represents the maximum blood pressure threshold for a patient to be eligible for TPA in the setting of acute ischemic stroke? A. Systolic blood pressure, SBP, 185 and diastolic blood pressure, DBP, 110, B. DBP 120, C. Mean arterial pressure 130, D. SBP 220 and DBP 120, E. SBP 140 and DBP 90. A. Systolic blood pressure. Answer A. Patients may be treated with leptalol or nitroprusside in order to reach this blood pressure goal if they are initially more hypertensive. Answer D represents the blood pressure limits that should necessitate antihypertensive in any patient with ischemic stroke. Patients with blood pressure below this threshold do not require treatment. Which of the following is true of Prinzmetal's angina? A. It is not relieved by nitroglycerin. B. It may be relieved by exercise. C. The pathophysiology involves acute plaque rupture with thrombosis. D. Characteristic EKG changes usually distinguish Prinzmetal's angina from acute myocardial infarction, MI. E. Beta blockers are contraindicated. B. It may be relieved by exercise. Answer B. Prinzmetal's or variant angina is characterized by chest pain caused by coronary artery vasospasm, which can result in STEMI, arrhythmia, and sudden death. Prinzmetal's angina can occur in concert with atherosclerotic heart disease or may be completely unrelated. A relative reduction in nitric oxide is hypothesized to be the cause. It is often clinically and electrocardiographically indistinguishable from atherosclerotic CAD. Patients with Prinzmetal's angina can have a decrease, increase, or no change in their pain with exercise. For this reason, history of exertional angina or exercise stress testing is of limited value in diagnosing Prinzmetal's angina. Variant angina may be relieved by nitroglycerin. Beta blockers, as in atherosclerotic CAD, form part of the cornerstone of management. Which of the following is the most appropriate medication to induce rapid, measured reduction of blood pressure in hypertensive crisis? A. Nifedipine, B. Isoproterenol, C. Phenoxybenzamine, D. Nitroprusside, E. Hydrochlorothiazide. D. Nitroprusside. Answer D. Only intravenous medications are appropriate for rapid, measured control of blood pressure. Nitroprusside is very easily titrated and extremely effective, making it the drug of choice for hypertensive crisis. Nifedipine has been associated with severe side effects due to its unpredictable response. Isoproterenol is a beta agonist and will not decrease blood pressure. Phenoxybenzamine is an alpha-blocking agent used mostly in the prevention of catecholamine surge during therapy for pheochromocytoma. Hydrochlorothiazide is an oral medication appropriate for outpatient therapy for chronic hypertension. A 35-year-old woman presents with severe weakness, lightheadedness, and chest pain. Her blood pressure is 70/40ths and her pulses are weak. The EKG is shown. Which of the following is the most important next step in management? A. Adenosine 6 mg IV, B. Diltiazem 20 mg IV, C. Amiodarone 300 mg IV, D. Synchronized cardioversion at 50 joules, E. Defibrillation at 200 joules. D. Synchronized cardioversion at 50 joules. Answer D. The EKG shows a regular, Narrow complex tachycardia at a rate of 175, most likely paroxysmal atrioventricular nodal reentrant tachycardia. The patient is hemodynamically unstable and synchronized cardioversion at 50 joules is indicated after appropriate sedation. In contrast to patients with atrioventricular nodal reentrant tachycardia and atrial flutter, patients with rapid atrial fibrillation, which can appear regular at high rates, do not typically respond to 50 joules for cardioversion. Thus, if the patient does not respond at 50 joules, the energy level should be immediately stepped up to 100 joules and then 200 joules, or to the equivalent energy dose if using biphasic equipment. Adenosine is the next best option, but hypotension and severe symptoms warrant more emergent conversion to sinus rhythm. Diltiazem and amiodarone can be used to convert the rhythm, but will cause further hypotension. Defibrillation is only indicated in patients who lack pulses, ventricular fibrillation, pulseless ventricular tachycardia.